There is something that many people over 65 experience that they almost never mention to their doctor because it seems too minor, too vague, too easily explained away. And that something is this: feeling cold when nobody else in the room is cold, sitting under a blanket when the thermostat says the house is warm, wearing an extra layer in the middle of summer, going to bed with socks on and a cardigan when the person sleeping next to you is perfectly comfortable. And maybe you have said to yourself, I just run cold. That is just how I am now. Or maybe your family has said it for you. Oh, that is just getting older. Your circulation is not what it used to be. And you have accepted that because it sounds reasonable, because it matches the narrative of what aging is supposed to feel like. But I want to ask you something today. How long has this been happening? Was there a time not so long ago
when you did not feel this way, when you were comfortable at the same temperatures as the people around you, when you did not reach for a blanket in a heated room? Because if the answer to that question is yes, if this coldness is something that developed or worsened over months or years, rather than something you have always experienced, then it is worth understanding why. Because persistent, unexplained coldness after 65, particularly when it represents a change from how you used to feel, is not always simply aging. It is sometimes the body's way of signaling something specific, something that has a name, something that can be tested for, and in many cases, something that can be treated. I am Dr. Daniel Chen, and today I want to walk you through the most important conditions that can cause persistent, unexplained coldness in adults over 65. What is happening in each case, how doctors identify them, and what can be done,
so that the next time you reach for that blanket in a warm room, you have a clearer sense of whether this is something worth mentioning to your doctor. Let us start with what actually regulates body temperature, because understanding the system that is supposed to keep you warm helps explain what might be going wrong. Body temperature in humans is maintained within a very narrow range, around 37 degrees Celsius, or 98.6 degrees Fahrenheit, by a sophisticated regulatory system centered in a part of the brain called the hypothalamus. The hypothalamus acts as the body's thermostat. It continuously monitors the temperature of the blood flowing through it and the temperature signals coming from sensory receptors in the skin. And it responds to deviations from the target temperature by activating a range of warming or cooling mechanisms. When the body needs to warm up, the hypothalamus triggers vasoconstriction, the narrowing of blood vessels near the skin surface to reduce heat loss, shivering, which generates heat through rapid muscle contraction, and increased metabolic rate to produce more internal heat. When the body needs to cool down, it triggers vasodilation, widening of blood vessels near the skin to increase heat loss, and sweating to cool the body through evaporation. Now, after 65, this thermoregulatory system becomes less precise and less efficient for several reasons. The hypothalamus itself shows age-related changes in its sensitivity and responsiveness. The peripheral blood vessels that are supposed to constrict in the cold to preserve core temperature respond more slowly and less completely. The shivering response, which generates emergency heat, is reduced in magnitude and occurs at lower temperatures than in younger adults. Subcutaneous fat, the layer of fat beneath the skin that acts as an insulating layer, tends to decrease with age, reducing the body's natural insulation against environmental cold. Muscle mass, as I discussed in my video on sarcopenia, declines with age. And since resting muscle metabolism is a significant source of internal heat, its loss reduces the body's baseline heat production. And peripheral circulation, the blood flow to the hands, feet, and skin surface tends to be somewhat reduced with age due to changes in blood vessel wall function and reduced cardiac output. In some older adults, all of these changes together mean that many healthy adults over 65 do feel somewhat cooler than they did at 40 and are more sensitive to environmental cold than younger adults in the same room. This is a genuine age-related change, and it explains why many older adults reach for a layer that younger people around them do not need. But here's the important distinction that I want to be very clear about. Mild age-related cold sensitivity is one thing. Significant, persistent, worsening cold intolerance, that represents a clear change from how the person felt in previous years, is something different. And it is the second type that I want to talk about today, because the second type has specific causes that deserve to be investigated. The first condition to rule out is hypothyroidism, an underactive thyroid gland. Of all the conditions that cause persistent, unexplained coldness in adults over 65, hypothyroidism is the most common, the most underdiagnosed, and the most completely reversible with appropriate treatment. The thyroid gland, which sits at the front of the neck, just below the Adam's apple, produces two hormones, thyroxine, also called T4, and triiodothyronine, also called T3. These thyroid hormones are the primary regulators of the body's metabolic rate, the rate at which cells convert fuel into energy and heat. When thyroid hormone levels are adequate, the metabolic rate is normal. Cells produce energy efficiently, and the body generates adequate internal heat to maintain core temperature and to keep the extremities warm. When thyroid hormone levels fall, as they do in hypothyroidism, the metabolic rate drops. Cells produce energy more slowly. Internal heat production decreases, and the body becomes less able to maintain its normal core temperature. The result is a persistent, often progressive cold intolerance that the person often notices as feeling cold in situations where they previously were not. Now, hypothyroidism is remarkably common in older adults. Research suggests that subclinical hypothyroidism, where thyroid function is impaired but not yet severely, affects approximately 10 to 15% of women over 65, and a smaller but still significant proportion of men in the same age group. And overt hypothyroidism, where thyroid hormone levels are clearly reduced, is also significantly more prevalent in this age group than in younger adults. The symptoms of hypothyroidism go well beyond cold intolerance. They include persistent fatigue that does not improve with rest, weight gain that occurs without significant changes in diet or activity, dry skin that becomes progressively more noticeable and resistant to moisturizer, hair thinning or increased hair loss, constipation that worsens progressively, brain fog, slower thinking, and memory difficulties that can mimic early cognitive decline, depression or low mood that was not present before, muscle weakness and aching, slowed heart rate, and a puffy or swollen appearance around the face, eyes, or hands. Now, here's what makes hypothyroidism particularly important to flag in the context of today's video. Many of these symptoms are individually common in older adults for various reasons. Fatigue, constipation, memory changes, weight gain can all occur in the context of normal aging or other conditions. And so hypothyroidism is frequently missed or attributed to aging, when in fact, a single simple blood test called a TSH test, thyroid stimulating hormone, can identify it, and effective treatment with thyroid hormone replacement using a medication called levothyroxine can reverse most of the symptoms, often dramatically, including the cold intolerance that may have been the most noticeable change for the person themselves. If you are persistently cold and you have any of the other symptoms I have described, particularly fatigue, weight gain, constipation, brain fog, or dry skin, please ask your doctor for a TSH blood test at your next appointment. It is one of the most simple, most informative, and most treatment-responsive tests available for a condition that affects a very significant proportion of adults over 65. The second condition is anemia. Anemia means that the number of red blood cells, or the amount of hemoglobin, the oxygen-carrying protein inside them, is below the normal range. Red blood cells are the vehicles that carry oxygen from the lungs to every tissue in the body, including to the skin and extremities, where oxygen is needed to maintain warmth and to support cellular metabolism. When red blood cells are reduced, less oxygen reaches the peripheral tissues, and the body responds by prioritizing blood flow to the vital organs, the heart, the brain, the liver, at the expense of the periphery, the hands, the feet, the skin. The result is that the extremities receive less blood and less oxygen than they need, and they feel cold, often profoundly cold, in a way that is not simply about room temperature, but about inadequate delivery of oxygen and warmth to the peripheral tissues. Anemia in adults over 65 is more common than many people realize. Research suggests that anemia affects approximately 10 to 24% of community-dwelling older adults, depending on the population studied, and its causes in this age group are varied. Iron deficiency anemia is the most common form overall and is caused by inadequate iron intake, reduced iron absorption, which decreases with age, or chronic blood loss, often from the gastrointestinal tract, including from conditions like peptic ulcers, gastritis, or colorectal polyps, some of which may be entirely asymptomatic. In older adults, this is one of the reasons why a new or worsening anemia in an adult over 65 should not simply be treated without first investigating whether there is an underlying gastrointestinal cause. That itself needs attention. B12 deficiency anemia, as I've discussed in previous videos, is caused by inadequate vitamin B12, often from reduced absorption due to declining intrinsic factor, or long-term use of metformin, or proton pump inhibitors, and produces a specific type of anemia called megaloblastic anemia, where the red blood cells are abnormally large but reduced in number. Folate deficiency can produce a similar type of anemia, and chronic disease anemia is extremely common in older adults, in whom chronic conditions, including kidney disease, rheumatoid arthritis, heart failure, and chronic infections, can suppress red blood cell production through inflammatory mechanisms. Anemia is diagnosed by a simple blood test called a complete blood count, which measures the number and characteristics of red blood cells and hemoglobin levels, and additional tests including iron studies, B12, folate, and kidney function are typically performed to identify the underlying cause. Treatment depends on the cause and ranges from iron supplementation, B12 injections, or folate supplementation to treatment of the underlying condition. In the case of chronic disease anemia, cold intolerance is one of the most commonly reported symptoms of significant anemia, along with fatigue, breathlessness, pallor, dizziness on standing, and a reduced exercise tolerance. If you are persistently cold and you notice any of these accompanying symptoms, a complete blood count is an important test to discuss with your doctor. The third condition is peripheral arterial disease. Peripheral arterial disease occurs when the arteries that supply blood to the limbs, particularly the legs and feet, become narrowed by atherosclerotic plaques, reducing blood flow to the peripheral tissues. Now, peripheral arterial disease is primarily a condition of the legs and feet, where it classically causes cramping pain in the legs that comes on with walking and is relieved by rest, a pattern called intermittent claudication. and cold feet that are often noticeably cooler to the touch
than the legs above them. But peripheral arterial disease also affects the hands and arms in some cases, causing cold hands and reduced hand circulation. That may be particularly noticeable in cool environments. The risk factors for peripheral arterial disease are the same as for coronary artery disease: high blood pressure, high cholesterol, diabetes, smoking, and advancing age. And it is significantly more common in adults over 65 than in younger adults. Peripheral arterial disease is diagnosed by a simple, non-invasive test called the ankle brachial index, which compares blood pressure at the ankle to blood pressure in the arm. A ratio below 0.9 indicates significant arterial narrowing in the leg arteries. If your feet or hands are persistently and noticeably cold, and if the skin of the feet appears pale or bluish, or if you have noticed any cramping in your legs with walking, please mention this to your doctor. As peripheral arterial disease is a significant cardiovascular risk factor, that warrants its own management plan, including risk factor control, and in some cases, medication or intervention to restore blood flow. The fourth condition is diabetes, and particularly poorly controlled or long-standing diabetes. In several ways, diabetes contributes to cold intolerance in older adults. First, diabetic peripheral neuropathy. As I discussed in my previous video on hand tingling, damages the autonomic nerve fibers that regulate blood vessel tone in the peripheral circulation. When these autonomic nerve fibers are damaged, the blood vessels in the extremities cannot regulate their caliber appropriately in response to temperature changes, and the hands and feet may feel persistently cold, not because of reduced blood flow, but because of impaired autonomic vasomotor regulation of the peripheral circulation. Second, diabetes is strongly associated with peripheral arterial disease, as I described, through its effects on accelerating atherosclerosis in the peripheral arteries. And third, diabetic kidney disease in people with long-standing diabetes may cause anemia through its effects on erythropoietin production, the hormone that stimulates red blood cell production, contributing further to cold intolerance through reduced oxygen delivery to the peripheral tissues. The fifth condition is poor cardiac output from heart failure or significant cardiovascular disease. The heart, in its role as the pump of the circulatory system, determines how much blood reaches the peripheral tissues, including the hands, feet, and skin surface. When cardiac output is reduced, either due to heart failure, where the heart muscle cannot pump with adequate force, or due to significant coronary artery disease that impairs heart muscle function, the peripheral tissues receive less blood, and the body, as I described in the context of anemia, prioritizes blood flow to vital organs at the expense of the periphery, leaving the extremities poorly perfused and cold. Cold extremities, particularly persistently cold feet in an older adult with a history of heart disease or with other symptoms including breathlessness, ankle swelling, or exercise intolerance that suggest reduced cardiac output, are worth discussing with a cardiologist in the context of cardiac function. The sixth condition is Raynaud's phenomenon. As I mentioned in my previous video on hand tingling, Raynaud's causes episodic rather than persistent cold in color change in the fingers in response to cold exposure or emotional stress. During a Raynaud's episode, the small arteries supplying the fingers go into spasm, causing the fingers to turn white, then blue, then red, as blood flow is cut off and then returns. The episodes are typically self-limiting, lasting minutes to about an hour, and are clearly associated with cold triggers or stress,
rather than being a continuous, constant coldness. Primary Raynaud's, which occurs without an underlying disease, is more common in younger women. But secondary Raynaud's, which is associated with underlying conditions, including autoimmune conditions such as scleroderma, lupus, and rheumatoid arthritis, is more common in older adults and is more likely to be severe and to cause complications, including digital ulcers in the most severe cases. If you experience episodic rather than continuous coldness, specifically in the fingers, with visible color changes, white, then blue, then red, particularly triggered by cold or stress, please mention this specifically to your doctor, because the investigation and management of Raynaud's is different from the investigation of continuous cold intolerance.
And secondary Raynaud's, in particular, requires assessment for underlying
Autoimmune or connective tissue conditions. Now, let me also mention two additional causes that are worth being aware of. The first is low body weight or significant recent unintentional weight loss. As I have discussed, subcutaneous fat acts as thermal insulation and reduced fat stores directly reduce the body's ability to retain heat. Unintentional weight loss in an adult over 65, as I mentioned in a previous video, is a red flag symptom that deserves medical investigation for underlying causes including malignancy, malabsorption, and metabolic conditions, and cold intolerance that appears or worsens alongside unintentional weight loss is a combination that warrants prompt clinical attention. The second is vitamin D deficiency. Vitamin D plays a role in muscle function and in metabolic rate regulation. That is less well known than its role in bone health.
Research has suggested that severe vitamin D deficiency
May contribute to reduced muscle thermogenesis, the heat generated by muscle metabolism, and thereby contribute to cold intolerance in some older adults. Given how common vitamin D deficiency is in this age group, as I have discussed, and given that checking it is simple and treating it is straightforward, it is worth including in the blood work discussion with your doctor if you are experiencing persistent coldness. Now, let me give you a practical summary of what to discuss with your doctor if persistent unexplained coldness has become part of your daily life after 65. Tell your doctor how long this has been happening, whether it represents a change from how you felt previously. Which parts of your body feel coldest, whether the coldness is continuous or episodic, and whether episodic coldness is associated with visible color changes in the fingers.
whether it is accompanied by any of the following: persistent fatigue,
Weight gain, constipation, brain fog, dry skin, hair loss, which would suggest hypothyroidism, breathlessness, pallor, dizziness, which would suggest anemia, leg cramping with walking, skin changes in the feet, or reduced sensation, which would suggest peripheral arterial disease, a history of diabetes, or poorly controlled blood sugar, ankle swelling or breathlessness, suggesting cardiac causes, or recent unintentional weight loss. Ask specifically for the following blood tests if they have not been recently done: TSH to assess thyroid function, complete blood count, including iron studies, B12, and folate to assess for anemia, fasting blood glucose, and HbA1c to assess for diabetes or prediabetes, vitamin D level, kidney function, including eGFR and creatinine, and an ankle brachial index measurement if peripheral arterial disease is suspected based on cold feet,
or leg symptoms with walking. These are not complicated investigations.
They are standard blood tests and simple clinical measurements that together can identify or rule out the most important and most treatable causes of persistent cold intolerance. In adults over 65, you have been reaching for that blanket in a warm room long enough. You deserve to know why and whether something can be done about it. Let me bring everything together now. Persistent unexplained coldness that represents a change from how an older adult previously felt is not simply aging. It is the body signaling something specific. The most important conditions to rule out are hypothyroidism, where reduced thyroid hormone lowers metabolic rate and heat production, and is diagnosed by a TSH blood test and treated effectively with levothyroxine. Anemia, where reduced red blood cells impair oxygen delivery to the peripheral tissues, causing cold intolerance. And diagnosed by a complete blood count, with treatment depending on the underlying cause. Peripheral arterial disease, where narrowed peripheral arteries reduce blood flow to the limbs, causing cold extremities. Diagnosed by ankle brachial index and managed through cardiovascular risk factor control. Diabetes and its complications, including peripheral neuropathy, peripheral arterial disease, and kidney disease, that each contribute to cold intolerance through different mechanisms. Reduced cardiac output from heart failure or significant cardiovascular disease that reduces peripheral perfusion, and Raynaud's phenomenon, which causes episodic finger coldness with color changes, and which in older adults may be associated with underlying autoimmune conditions. None of these is a diagnosis I can make for you from a video, but all of them are conditions that a doctor with the right information, the right blood test, and the right examination
can identify or confidently rule out. You went to that video looking for an explanation for something that has become part of your daily life, reaching for a blanket that nobody else in the room needs. I hope today I have given you a clearer picture of where to look and what to ask for. I am Dr. Daniel Chen. If this video helped you understand something you have been living with but never fully explored, please share it with someone over 65 who is also always cold and has been told it is just getting older. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me how long you have been feeling persistently cold and whether you have ever had your thyroid function checked. I read every single comment, and I genuinely look forward to hearing from you. Take care of yourself.
And the next time you reach for that blanket in a warm room, remember that your body is trying to tell you something, and now you know where to start listening.